Thank you for having me. As you heard, I'm from New York City. I'm a neurologist. I see both children and adults, primarily with autoimmune disorders and mainly affected by infections. You've heard about strep, but you'll hear about other things as well. So let's get started. I'm going to talk about a couple of cases. I'll present a few cases, and there's a reason for each one. Define what autoimmune is, and I'm sure you'll hear more about it later today. Clinical presentation, some pathophysiology, how it's diagnosed and how it's treated, and some common mistakes that I see made in when patients come to me, and some new developments and new treatments. So the first case is of a 59-year-old woman, and I included her because she's not a child, so this can present in adults, who had a one-year history of various neurologic complaints, including fatigue, unsteadiness, speech difficulty, poor dexterity, cognitive decline, and then she presented to an emergency room with acute onset of weakness and was worked up for a stroke. That workup was actually negative, but what was abnormal was that she had an abnormal SPECT scan, and I'll talk about what that is in a little bit, and then she had an abnormal EEG as well. When she arrived to me, we did some extensive blood work, and she tested positive for a lot of infections, including respiratory and tick-borne. I'll talk, the treatment for these patients will be addressed in my talk. So this is your a typical presentation of a 6-year-old with onset of treatment at age 4 with fatigue, leg pain, some regressive behavior, bedwetting, stomach pains, as you just heard, and she was actually diagnosed and treated for strep. This woman, again, is a typical case in my practice, a 21-year-old woman with symptom onset at age 14, mainly psychiatric symptoms with some neurologic presentation as well. And she's had 3 inpatient involuntary psychiatric hospitalizations over 7 years. She was followed by Mass General Psychiatry Department and have tried multiple psychiatric treatments, all of which have failed. And when she arrived to me, she's had hyperreligiosity, intrusive thoughts, severe anxiety, and headaches. And her workup was fairly benign from the standpoint of her MRI showed some non-specific changes. She had a DVA, which was an incidental finding, a normal EEG. Her LP was, she had 2 oligoclonal bands. That's considered normal, but she had no other significant findings there. The SPECT scan was abnormal with hypoperfusion. But with some specialty blood work, she did have tick-borne infections that were identified. She had an antineuronal antibody identified, and she had an abnormal Cunningham panel as well. And she needed to be treated with both for the infectious etiology with antibiotics, and we treated her autoimmune disease with IVIG and plasmapheresis, and she actually got stem cells too. So what is autoimmune encephalitis? It's really the production of antineuronal antibodies against your own brain. And that happens when you have a break in the blood-brain barrier, which causes an insult to the nervous system. It causes presentation of inflammatory cells in the brain matrix with the increase in lymphocytes under the microscope. That's what we see. And disruption of glial cells, which are the supportive cells of the nerves. And what's the cause of this autoimmune encephalitis? Well, when I was in training, we thought that it could be post-infectious, most commonly thought to be malignant, and then the rest was idiopathic. Right now, we think maybe 40% or less is malignant, and about 60% is idiopathic. And what I see in my practice that a lot of these patients actually do have an infectious etiology. So this is a slide that I created, and that's kind of how I think of autoimmune encephalitis, where PANS and PANDAS is just a part of that, but a lot of it could be an infectious-induced process, malignant, environmental, potentially even vaccine injuries, and other that can cause this clinical presentation that can have very different phenotypes, as you see in the case presentations that I've shown earlier. In terms of the definition of it, we have, as we heard Dr. Najjar, and I think you have that in your packet, I do include some of his work in this presentation as well. But really defining it in the clinical setting, patients have major depression symptoms, bipolar disorder, schizophrenia, OCD. And they may also present with seizures and cognitive decline. And the reason for that is, again, this creation of these anti-neuronal antibodies. So your own body is fighting itself. So the clinical presentation, again, can be very vast. Specifically, the psychiatric symptoms are very impressive, as you heard earlier today, and very difficult to deal with. There's often a decline in memory. They can present with seizures. They can also have movement disorders, as you heard, with dystonic movements, chorea, rigidity, myoclonus, and cerebritis, inflammation of the cerebellum, and some ataxia, including a lot of eye movement abnormalities that can be very subtle. But what I see in a lot of children, they'll complain about reading, and that's because their eyes are not tracking properly. So that's the reason for that. This is a quick slide of what really happens with these anti-neuronal antibodies, where our brain and our neurons communicate through signaling molecules, neurotransmitters, and in the setting of, these are two different types of autoimmune encephalitides, but in one case you have a decline in the receptors that receive these neurotransmitters, and in other cases you just develop antibodies to block them. So essentially the message is blocked from going from point A to point B, and that's why we have different clinical presentations. So how is it diagnosed? A lot of times, especially these two, and a lot of like the blood work, the lumbar puncture is normal, but I'll go into that a little bit. So we'll do an MRI, and again, some of this is to diagnose, and some of this is to rule out other things that may be causing the clinical symptoms. So we'll do an MRI, an EEG, a brain SPECT, and brain PET scans are done. A lot of the times when you go to medical conferences, the researchers will talk about PET scans, which are here. Yes, it is a better study than the brain scan. However, it's often not approved by insurance. So in my practice, I'll use the SPECT scan, which I think is a good study for these patients. It's not necessarily a diagnostic study, but it helps to support if it's abnormal, which a lot of times I find it is. It kind of helps to support the clinical picture in patients. Then we do the blood work. So this is, a lot of this is from the Mayo Clinic. And there's some labs, for example, Quest Lab or My Local Lab, they actually have a panel. So you don't have to order a particular test, you just order the Mayo Clinic panel. In order to increase the sensitivity of this test, because it can be insensitive, I will order some of these antibodies by themselves. For example, the potassium channel receptor antibodies. The most common autoimmune encephalitis and is the NMDA receptor, or at least based on the medical literature. However, in my clinical practice, I see that the GAT65 antibody is abnormal a lot in the patients that I see. Then the LP, and again, you can run the same autoimmune encephalitis panel in the lumbar puncture, but honestly, often the LP will come back normal. And then for school, you may want to do neurocognitive assessment, and the patients initially, when we started figuring out what's wrong with these patients, we didn't know. Brain biopsies were done. We don't routinely do them now, but that's how we found out what was wrong with the brain matrix, with the lymphocytes and the glial cells. So this is an MRI of the head, and this is a clear, I mean, in the brain, it's pretty straightforward. You want the right side look the same as the left side. This clearly has mesial temporal lobe abnormality in this case. Here, this is more common. What I see in my practice is either a normal MRI or this non-specific white matter changes, which you see here. There's little arrows there, which a lot of neurologists and mainstream radiologists and neurologists will basically say, oh, it's non-specific, it can be because of a headache, but can often be seen in the clinical setting of autoimmune encephalitis. EEGs, again, this is an abnormal EEG because the patient has an abnormality here with inflammation of this part of the brain, so they have little sharp things. Basically, on an EEG, you don't want to be able to sit on something and it's going to prick you. So if you see that, something sharp, it's not good. You want your EEG to look like this, which is the most common presentation that I see with the autoimmune encephalitis. As you see, it's really frustrating because the patient's struggling and a lot of the testing is non-specific or normal. This is a brain SPECT scan, and here's a perfect presentation where patient is struggling. The MRI looks completely normal, but when you do a SPECT scan, you see that the frontal lobes are not perfused the way they're supposed to. And this is the antineuronal antibody panel, which I found on the Mayo Clinic website, and you can find it as well. In terms of talking about the PET scans and the antineuronal antibodies, so about 50% of patients who are clinically suspected to have autoimmune encephalitis actually test negative on the antineuronal antibodies. So we have basically identified only about 50%, if not less, of the antineuronal antibodies that are available. And actually, looking at it, so these are the patients who are seronegative, meaning that their antibodies are negative, but they're clinically presenting like they have autoimmune encephalitis. And the phenotype between these two patients, meaning the way that they look clinically, is the same. So what do we do? Well, we have some other testing, Cunningham panel, to kind of expand beyond the about 15 antineuronal antibodies that are available through Mayo. There's some additional antineuronal antibody through specialty lab called Moleculara with their Cunningham panel. So I use that in my practice. And what they often talk about is what's the reason for having these antineuronal antibodies, and strep is definitely one of them, and so is mycoplasma, but so is Lyme disease and tick-borne infections, and I'll touch a little bit more on that. Last week was telling a patient that I was coming to this conference, and she gave me a tip and said, you know, can you just tell them a little bit more about the infections and what you do in terms of what testing to order, just to give you guys a hint of what I order for my patients. So this is the molecular lab order sheet, and this is how it comes up, and you'll hear more about it later today. But in order to test positive on molecular, you really need to have only one out of all the antibodies that they test for. And then there was one talk about chem kinase, which is a protein that can be elevated. And again, you'll hear more about it today, that we think that there may be some association with it in the setting of an acute infection or a reactivation of infection. So when this number is high, there could be an infectious component there. And again, strep, mycoplasma is important to check for. Lyme, Bartonella, Babesia, and other tick-borne diseases can contribute to this as well. Some viruses, candida, certainly mold, environmental toxins can contribute to the clinical picture. MCAS, which is mast cell activation symptom, where you have an increased amount of inflammation in the body through various allergens and other things as well. So when we talk about Lyme specifically, if we're using routine testing through regular blood work, I just want to make people aware that only about 56% of that blood work is sensitive. So we're missing a lot of the cases if we're using the CDC standard regular blood work approach in diagnosing Lyme disease, and if we're relying solely on the blood work. I want to also mention that a lot of the patients who do have Lyme, once you diagnose it, can have other co-infections. I specifically point to Bartonella because it can present with this type of skin finding, and it's obviously easy to see. In terms of Bartonella itself, it can cause a lot of neurologic symptoms such as aphasia, encephalopathy, neuropathy, seizures, and even inflammation of the spinal cord. And the Babesia can cause some neurologic symptoms as well, and some hematologic issues. And again, in order to diagnose these infections in Lyme, Babesia, Bartonella, I specifically use IGeneX lab because I find that they have higher sensitivity. It's obviously, as you see, there's a slew of testing that you can have done. I use the Immunoblot, it's right here for the Lyme, and I'll use the Babesia IgM, IgG testing. You can also do some PCR and fish testing, but that's what I use, this IGeneX lab, in order to diagnose Lyme and Babesia to increase my yield for that. And for Bartonella specifically, I use Galaxy, again, because I find that it increases the yield of testing, and that's the one I use most often, Bartonella Hensley immunofixation assay. So when we talk about how these infections can impact autoimmune encephalitis, this is a paper, I believe it's actually in your handout, where infections may increase the risk of psychosis either acutely or later on in life. And again, that's looking in patients in the United States and abroad over many years. And neurology and psychiatry are not the only specialties who've recognized that. Our friends from the ENT department have noted that as well and published some case studies. That particular article shows 150 patients with sinusitis, 10 of them who presented with anxiety, mood disorders, panic attacks, learning disability, OCD, and 8 out of 10 improved with treatment of the sinusitis. So what is the treatment? Identifying and treating the underlying cause and looking hard and treating the infections is no small task, as you see, and then addressing the autoimmune aspect of it, including using IVIG, plasmapheresis, exosomes diet, neurofunctional training, and I'll touch on all of those. So immunoglobulin treatment, and I believe you may hear a bit more about this later again. It's a blood product. It's pulled from thousands of donors and checked and cleaned for infections. It functions by helping to modulate the immune system in special doses, which I'll address. And it prevents immune system from attacking itself and allows the body to heal. And this is why treatment for, in some cases, many months and even years is important, because how long does it take for the body to heal itself? It really depends on the patient and the level of their immune system, other infections or environmental toxins that may be triggering their clinical presentation. So I actually subscribe to this recommendation, where I treat patients with high-dose IVIG, which is anywhere from 1.5 to 2 grams per kilogram on a monthly basis. I think that it is more difficult to tolerate as a onset treatment, but later on patients find more benefit. And this is a publication that was talked about how the higher dose of IVIG is actually immune modulating versus the dosing that is, I think, easier to tolerate at 200 to 400 milligrams per kilogram weekly is actually more immune replacement, and I don't think it's really appropriate for our patients. I would say most of my patients receive the high dose unless there's something going on and we have to alter that treatment. I do have to explain to you that most physicians who treat with IVIG actually believe that these two doses are interchangeable because these publications, there's not too many of these publications, and people just use the doses interchangeably, which I don't think is appropriate for our patients. This is something that I've presented, a poster presentation at ILADS, talking about IVIG and duration of treatment. So that we took 30 patients with some tick-borne diseases who were treated appropriately for their tick-borne diseases, but despite that continued to have clinical symptoms, mainly neuropsychiatric, with headaches, insomnia, visual problems, cognitive impairment, fatigue, and psychiatric symptoms. And we worked them up for autoimmune encephalitis. For this study, 100% of our patients did have an antineuronal antibody. And we've continued treating them with their infection, for their infection, and we added IVIG to their clinical regimen, and all of the patients showed benefit. Most of the patients, 70% of the patients, required 6 or more months of treatment. So if your patient is receiving IVIG and or your family member is receiving IVIG and is not seeing benefit after the first or the second treatment, I think giving it more time and then making sure that they're on a proper dose. And if they're not responding to treatment, also looking for infections and adding that to their treatment plan shows big benefit. Plasmapheresis is something that I use in my practice as well. I use this dosing, which is about 1.5 exchanges over a course of 3 to 5 days. So they get about 4.5 to 6 exchanges as tolerated. And they do that on a monthly basis for anywhere from about 3 to 6 months. I don't use it continuously because plasmapheresis is immunosuppressive regimen, and many of my patients do have infections. And therefore, I will implement plasmapheresis in addition and then add in IVIG immediately after their pheresis. Which is safe and reduces their immunosuppressive quality. So common mistakes that are made is that we're giving the wrong dose of IVIG, and that may stimulate production of antineuronal antibody instead of doing what we actually want, which is modulating the immune system. Not treating the infection is another issue, and not treating long enough. Most of my patients will be treated for at least 7 to 9 months continuously on the dose that I was mentioning, and most patients will be treated for about 2 years until they can come off the monthly IVIG. And then adding immunosuppressive therapy to treatment regimen without covering for infections. So if patients require steroids, I'm okay with it. However, if that's the case and if they do have infection, they need to be on antibiotic at the time of receiving steroids. And the same thing with plasmapheresis. So some of the kind of new developments is using exosome therapy, a fasting mimicking diet, some neurofunctional training. So exosomes are extracellular vesicles. They signal by transferring their content from one cell to another. They are nanoparticles. They're extremely small. They can easily penetrate the blood-brain barrier. They contain messenger RNA, microRNA, proteins, and they're derived from mesenchymal stem cells from placenta, and they're rich in growth and immunomodulatory substances. As you see, immunomodulation is what I really like, so I'm a fan of the exosomes. What's the advantage of exosome treatment versus the stem cell treatment? They're not clumping because they're so small. They don't get trapped in the lung, which is a concern for the stem cells. They pass easily through the blood-brain barrier because, again, they're small. They don't contain DNA, so no risk for malignancy. And there's it's not recognized as a foreign object by the immune system. Okay, so how do they work? How the immunomodulation works? So there's two ways we control inflammation. So macrophages and microglia have two properties. One is the M1 system, which is the pro-inflammatory, and the M2 system, which is the anti-inflammatory. What the exosomes do is they help to guide the M1 to convert to M2, so creating an anti-inflammatory state in the body, and that's what we want. Again, with the T helper cells and the T regulatory cells, we're down-regulating inflammation, going from Th1 to Th2, which stimulates B cells and reduces inflammation. They also secrete anti-inflammatory cytokines, and they reduce cell death by containing 5 enzymes to improve ATP and glycolysis. What's the indication for exosomes, which I really think of as like the active ingredients of stem cells. So in the neurodegenerative process, in the CNS injury and trauma. So when I talk to educators about autoimmune encephalitis and they ask how to deal with these children, I talk to them that this, it's the same clinical presentation as head trauma. So here we're talking about chronic traumatic encephalopathy, and this is really what's going on with the kids. So treating various neuropathies, seizures, autism, depression, and various other indications as well. These are the treatment plans, so intranasal, IV, intrathecal, nebulizers. Intranasal is very interesting because you actually get like a pump of the exosomes that you inhale every 3 hours over a course of 3 days, and because they're so small, they're able to penetrate the cribriform plate and get into the brain, and it's kind of microdosing and reducing inflammation over a prolonged period of time. So now I'm going to talk about a fasting mimicking diet. This is, in my opinion, not appropriate for children, potentially older teenagers and adults. That's something that they can do, but this was developed by a physician, a PhD out of California, and it's a 5-day fast fasting mimicking diet, where you essentially consume about 800 to 1,000 calories for the 5 days, and then you refeed for the rest of the 25 days into a normal diet, which he recommends to be a Mediterranean diet. And that it should be done in the setting of encephalitis for 3 months, and then you do subsequently once every 6 months for maintenance. And what it does is it reduces the inflammatory marker, the IGF, which causes speed in aging, blocks cellular regeneration, and blocks multiple system regeneration. So we're reducing that factor. And it actually increases stem cell production as well. So body enters into the protective and stress-resistant mode and removes damaged cells and promotes self-repair. And that actually, the stem cell part of it actually happens day 6 to 9 after treatment, after the fast, which is why you don't want to be going to McDonald's and refeeding there, because your stem cells, right, are working hard at that time. There's another thing that I love is neurofunctional training. Basically neurofunctional training, brain, body, education. It's really more of a lifestyle than a therapy, and I don't think it's necessarily appropriate for an acute exacerbation or when you're in crisis mode, but this is something that essentially you use to rewire the brain for better health through self-talk, kinesiology, and life education. And I've attended a couple of lectures from a woman who runs the Neurofunctional Institute out in Colorado. And a lot of this work is actually based on this book, The Brain That Changes Itself. And there are some tools online that you can find. They're outlined in this book, which helps to essentially retrain your brain. And I think it's a great tool as an adjunct treatment for a lot of my patients. I wouldn't necessarily recommend using just that. So I do offer phone consultations to both physicians and patients. If you're far away or if you've tried many different things and you just have some questions as to what to do next, what options are available to you, you can contact me on the phone. And these are some of my other contacts. This is my website where there's some newsletters, some articles for resources, and then I have a YouTube channel where presentations like this may be found, and then Instagram and Facebook. And because I treat a lot of tick-borne diseases, I've created the product line to prevent that, and you can find it on my website and on Amazon. And that's all I have for you today.